So it's very important to think about the sex differences in therapies for heart failure in men versus women. Let's start with HFrEF, heart failure with reduced ejection fraction, where we already know there are phenomenal therapies that help patients feel better, stay out of the hospital, live longer. Optimal therapy being the angiotensin receptor neprilysin inhibitor, the evidence-based beta blocker, the mineralocorticoid antagonist, and the SGLT2 inhibitor. It's important to note that if you look at randomized controlled trials that establish the benefit of these incredible therapies, women are very underrepresented, maybe 20% of the population of all these trials, because whether that's historic, whether that's policy, whether that's HFrEF, maybe a little less common in women. With that being said, we have an underrepresentation of women in HFrEF trials. We have an extraordinary benefit overall. We also know that in subgroup analyses of these trials, in some cases, there's benefit in both men and women. In some, there's benefit in only the male subgroup, some only the female subgroup. But here's my take when it comes to HFrEF. We know we have extraordinary therapies that work, and we know that subgroup analyses are hypothesis generating only. So because of that, when it comes to HFrEF, we treat men and women with the same guideline-directed medical therapy, the best quadruple therapy. Now, a subtle point that it's important to think about when you're thinking about HFrEF, we all know how important it is to titrate to optimal doses. What is optimal dosing of GDMT in men versus women with HFrEF? Well, there's some analyses to suggest that women may get the same benefit at lower doses, but this isn't entirely clear. So I still titrate doses in all patients, regardless of sex, to tolerance, assuming that potentially women will tolerate lower doses than men pharmacologically, but still do my best to get them there. Now, HFpEF is a bit of a different story because there is a dearth of effective therapies to help patients feel better, stay out of the hospital, live longer. What we can say when it comes to HFrEF is the SGLT2 inhibitors are extraordinary. They actually are the first, both Emperor preserved and then deliver met their primary endpoint, the first trials of medications of HFpEF to do that. So empagliflozin, dapagliflozin are extraordinary. We know that when it comes to HFpEF trials, what's very interesting is that these trials are almost 50% women because HFpEF is so much more common in women. So we have more representation, and we know that the benefit is both male and female subgroups. The mineralocorticoid antagonist, spironolactone, very interesting. The TopCat trial, we have a reduction in heart failure hospitalizations, benefit in both men and women. This is an important medication. The ARNI, the angiotensin receptor neprilysin inhibitor, sacubitril valsartan, studied in Paragon HF. This is a puzzling one. The primary endpoint was not met. The secondary endpoint of heart failure hospitalizations was almost met, p-value 0.06. And if you look at the subgroup analysis, there was benefit in women, but not men. And there was benefit at the lower end of the EF spectrum, but not the higher end of the HFpEF EF spectrum. Now, do we trust this subgroup analysis? I just told you that subgroup analyses are hypothesis generating. I think on some level we have to, in the sense that we have so much less to offer patients with HFpEF. So when it comes to HFpEF, I will give all my patients the SGLT2 inhibitor. I'll give all my patients the MRA, and then I will preferentially consider ARNIs for women. It's so hard to tease out the difference between biology and disparity. And I think it's really extraordinary that the 2022 ACC, AHA, HFSA heart failure guideline has a really important table, table 27, that highlights the risks of heart failure and outcomes in special vulnerable populations, including women, older adults, those of lower socioeconomic status, Black, Hispanic populations, Native American populations. So I think it's important for us, number one, to document these disparities, and then number two, identify the mechanisms for these disparities, because we cannot change if we do not understand the underlying causes. So that's more on a policy level, that's a society level. But when you're standing with that patient in front of you, I think it's important to recognize if they exist in one of these vulnerable classes and make sure that you are doing everything on your part, one patient at a time, to optimize their therapies and discuss with them the next steps of advanced therapies if they are eligible and interested. Yeah, social determinants of health are something that can be very challenging to study. The studies are by definition observational, so it's hard to truly tease out the impact of biology versus disparity in many of these social determinants of health. We know very clearly that women might have more favorable survival with heart failure than men, but they may have lower quality of life. They have greater mortality on the transplant waiting list. We know that older adults, of course, have worse survival with HFrEF. We know that patients of lower socioeconomic status will have increased mortality when judged based on employment, poverty, education. We know that Black populations have greater mortality with HFrEF than non-Black populations. And we know that that also can hold true for other vulnerable groups. So I think the best thing to say is it's hard to know the cause of this. Certainly there is a signal here, but how much this relates to a difference in the biology of the disease or how we as a society approach the disease is not clear. Yeah, well, we know that cough from ACE inhibitors is more common in women than men. However, ACE inhibitors are no longer first line for HFrEF, so hopefully you never have to encounter that situation because you'll give all your patients an ARNI. SGLT2 inhibitors can increase the risk of urinary tract infections, a side effect, a consequence of the glucosuria. Whether that's more common in women than men, I think is not relevant when you balance out the benefit of this medication to patients with HFrEF and HFpEF, heart failure across the EF spectrum. So I try to tell my patients to educate them about good hygiene and the signs of a urinary tract infection. But ultimately, because these medications are so critically important, I wouldn't withhold them out of concern that a female patient may develop a urinary tract infection. I think there's truly a desire to give patients individualized, personalized care, precision medicine, personalized medicine. These are all hot topics, but we have to take a step back and say, do we really have the data to support it? Because subgroup analyses are hypothesis generating. And if large clinical trials show a benefit in the entire population, I think we have to focus on applying the right medications to who fits that clinical trial population, as opposed to parsing out subgroup analyses, which may or may not be valid or reproducible. That being said, when there's more of a dearth of knowledge, as in HFpEF versus HFrEF, we may take more stock in subgroup analyses because we have less overall to offer our patients.